Today, we are taking a granular look into a condition that is, it's medically complex, often emotionally devastating, and actually surprisingly common.
It really is.
We're talking about the brain aneurysm, also known as a cerebral or intracranial aneurysm. It's a true paradox in neuroscience.
It is, because when you look at the statistics, this is not some rare disease. We're talking about something that could affect up to, 10, 12 million people in the U.S. alone?
That's a huge number.
It is. Prevalence estimates consistently put it at somewhere between 1 and 5% of the general population. They could be harboring an unruptured aneurysm right now.
And for most of those people, it's silent.
Completely silent. For the vast majority, it will stay small, totally harmless for their entire lives.
But the danger, and this is what we're here to untack, is that dual nature. Because if that small, silent bulge ruptures, you're looking at a subarachnoid hemorrhage.
Which is a catastrophic type of hemorrhagic stroke.
Yep.
Mortality rates are extremely high.
Right. So our mission today is to go way beyond that immediate crisis. We want to unpack the nuanced pathophysiology, the why behind the vessel wall failure.
And explore that cutting-edge treatment battle, the classic clipping versus coiling debate.
And most importantly, I think, is to reveal the long-term realities of recovery, the things that are often invisible for the people who do survive.
And to set the stage, let's start with a surprising fact that really challenges our typical assumptions about cardiovascular disease.
Okay.
We tend to associate these issues with older age, but brain aneurysms frequently strike adults between 30 and 60 years old.
So people in their most productive years.
Exactly. And in so many cases, the patient walks in with few, if any, of the conventional risk factors we usually look for. That's what makes this silent threat so difficult to get ahead of.
Okay, let's start at the beginning then, the science of failure. We use words like bulge or ballooning, but what is fundamentally happening to the structure of those blood vessels in the brain?
The core definition of an aneurysm is that localized weakness in the vessel wall. So if you imagine an artery as a kind of multi-layered hose pipe,
Right.
if one of those layers starts to degrade, the constant pressure of the blood pushing against it forces the inner lining out. And that's your fin sac.
So it's the unrelenting force of blood pressure acting on a defective piece of the wall.
Precisely. And what's really crucial here is that this expansion process is self-reinforcing. It's actually governed by physics.
We're talking about the Young-Laplace law, which sounds more like engineering than medicine. How does that apply here?
That's a perfect application. The law basically dictates that the tension in the wall of a sphere, in this case the aneurysm sac, is proportional to its radius.
So in simpler terms?
The bigger the aneurysm gets, the more tension is required to contain the same amount of blood pressure.
Ah, so even if a person's blood pressure is stable, a larger aneurysm is under inherently more stress than a small one.
Exactly. It creates this vicious cycle of growth and weakening, accelerating the process and making it more and more unstable.
So the bigger the defect gets, the easier it is for it to grow even more. That magnifies the risk. And structurally, where is the failure happening? What layer of the vessel wall are we talking about?
When you look at these walls under a microscope, you find these very distinct defects, especially in the tunica media.
That's the middle layer, right, the muscle layer.
That's the one. It's mostly smooth muscle cells, and it gives the artery its structural integrity. In an aneurysm, that layer is often incredibly thin, or sometimes it's just completely absent at the site of the bulge.
And that's not the only problem.
No. To make it worse, the internal elastic lamina, which is the layer that gives the artery its resilience, its bounce, is often fragmented.
So you lose the muscle and you lose the elasticity.
And the vessel has basically no structural defense left against that internal pressure.
It sounds like a failure just waiting to happen. And we know these failures aren't random. They tend to cluster in very specific areas of the brain's vascular network.
That's right. The vast majority of these saccular aneurysms form in the arteries at the base of the brain, specifically around the circle of Willis.
And why there?
It all comes down to mechanical stress. Aneurysms love arterial forks or branch points. Those spots are naturally subject to higher wall, shear stress, and more turbulent blood flow.
Like a river splitting in two.
Exactly. Think about the force of the water slamming into that dividing point. It causes erosion. Over years, over decades, that constant high stress on the wall initiates the damage that leads to the ballooning.
So let's clarify the different types, because not all aneurysms look or behave the same way. The majority are the saccular or the berry type, right?
That's the one we've been discussing, the saccular or berry aneurysm. It's the classic image, that spherical sac connected to the artery by a neck.
Looks just like a berry hanging on a stem.
It does, and they account for about 90% of intracranial aneurysms. They are the primary source of that subarachnoid hemorrhage we talked about.
But then you have the fusiform aneurysm. How is that different?
A fusiform aneurysm is more of an elongated swelling. Instead of a sac protruding from one side, the entire artery dilates on all sides over a longer segment. These are often related more to atherosclerosis, hardening of the arteries, rather than that bifurcation stress.
And then there are aneurysms caused by something else entirely, like an infection.
Exactly. Mycotic aneurysms are a whole different ballgame. They're caused by what we call septic emboli.
So, bits of infected material traveling in the bloodstream.
Right, often from an infection on a heart valve, something like endocarditis. That material travels to the brain, gets lodged in an artery, and the infection itself just erodes and weakens the artery wall from the outside in.
Which highlights a completely different pathological pathway.
And sometimes connected to things like intravenous drug use, which can introduce those infections into the body.
And finally, we should touch on the microaneurysms. This is a really important distinction because they cause a different kind of stroke.
This is critical for clarity, yes. We're talking about microaneurysms, specifically the Charcot-Bouchard type. These are tiny, less than 300 micrometers.
Oh, microscopic.
Practically.
Yeah.
And they occur deep within the brain's penetrating arteries, usually in the basal ganglia.
And unlike the saccular ones that rupture into the space around the brain,
these rupture into the brain tissue itself. They're a very common cause of intracerebral hemorrhage, or ICH, not subarachnoid hemorrhage, or SAH.
And they are overwhelmingly linked to one specific risk factor.
Chronic, severe, uncontrolled hypertension. High blood pressure just pounds those tiny, deep vessels until they give way. So, key distinction. Saccular aneurysms cause SAH. Charcot-Bouchard microaneurysms cause ICH.
That makes perfect sense. Okay, let's move to the why, the risk factors. We've established that the vessel weakness is fundamental. What are the acquired habits that accelerate this process?
The acquired factors, the ones we can actually counsel patients on, are largely what you'd expect: vascular insults, and cigarette smoking is probably the single most destructive factor.
More than anything else.
Arguably, yes. It just damages the integrity of the vessel lining, the endothelium, and it promotes inflammation. It dramatically increases the risk of both aneurysm formation and rupture.
And you couple that with the constant mechanical stressor.
High blood pressure, hypertension. That's the relentless physical force that's pushing that weakened wall to its breaking point, day in and day out.
And certain illicit substances can act like an acute multiplier on that pressure?
They absolutely can. Cocaine and methamphetamine use pose an extreme acute risk. They cause these sudden, massive surges in blood pressure that can rupture a vessel that might otherwise have stayed stable for years.
Right.
And, of course, heavy chronic alcohol use is also associated with an increased risk. Then there are the demographic realities. Aneurysms are a bit more common in women, about a 3-to-2 ratio, and the incidence peaks between ages 30 and 60.
So let's pivot now to the non-modifiable risks, the genetic component. If a person avoids all those lifestyle risks, why might they still be vulnerable?
This is where we see some of the most tragic cases, and it's the strongest evidence that this is often an inherited condition. A strong family history is the clearest predictor we have.
So if a close relative has had one?
If you have 2 or more first-degree relatives, a parent, a sibling, a child, who have had an aneurysm or an SAH, your personal risk profile is drastically higher. It just suggests a shared, inherited weakness in the connective tissue.
And beyond just general family history, there are specific genetic diseases we screen for aggressively.
Absolutely. Conditions that affect collagen synthesis, the body's scaffolding, things like Ehlers-Danlos syndrome or Marfan syndrome, they inherently weaken blood vessels everywhere, including the brain.
There's also a really strong link with a specific kidney disease.
Yes, autosomal dominant polycystic kidney disease, or ADPKD. Patients with ADPKD have defects in some of the same molecular pathways that are involved in connective tissue stability, so we have mandatory aneurysm screening protocols for them.
Other structural issues seem to be correlated too, suggesting a more widespread fragility.
We see that. Patients with coarctation of the aorta, which is a congenital narrowing of the main artery from the heart, are at increased risk. And also the presence of a brain arteriovenous malformation, or AVM.
which is the abnormal tangle of vessels.
Right. It completely changes the local blood flow dynamics, putting a ton of extra stress on the adjacent arteries.
So this strong genetic component leads us right to the future of prevention. Because right now, screening is very limited. It's really just for those very high-risk family groups.
And that's not good enough. The field desperately needs a way to screen the general population, people who might have just one affected relative or no known history at all.
And that's the goal of initiatives like the RAR DNA project, right?
Exactly. It's a massive world-leading effort. We know about 16% of patients have an affected parent or sibling, but the genetic linkage is almost certainly wider than that.
So what are they doing?
They're collecting and analyzing genetic data from thousands of patients all over the world to try and pinpoint the specific genetic markers.
Not just for formation, but for rupture too.
That's the critical part. The markers that determine when an aneurysm transitions from being stable to being unstable and prone to rupture.
So the goal isn't just a cure, it's a personalized early warning system.
That's the holy grail. If we can isolate a gene or a cluster of genes, we could potentially develop two things. First, a targeted, non-invasive screening program.
Like a simple blood test.
Imagine that. A blood test that could identify millions of at-risk people decades before a crisis. And second, and this could be even more impactful, we could develop new prophylactic drugs.
So if you know a specific genetic defect is weakening the wall,
maybe we can create a medication that stabilizes it, or reduces that localized inflammation, or just prevents the aneurysm from growing in the first place. That would allow us to avoid invasive surgery altogether. It's the absolute epitome of precision medicine for a devastating disease.
Okay, let's shift gears from the risk factors to the acute clinical picture. When we move from that silent ticking time bomb scenario into a symptomatic phase, what are the key signs? What happens when an unruptured aneurysm starts causing trouble?
For the vast majority, small, unruptured aneurysms are completely asymptomatic. They're what we call incidental findings.
Found on a scan for something else entirely.
Exactly. But as it grows, it starts to act like a mass. It begins pressing on adjacent brain structures or cranial nerves.
And that causes specific symptoms.
Yes, and the most common ones are related to the ocular nerves. Things like a localized pain, often described as being above or behind one eye, a dilated pupil on one side, or sudden vision changes like double vision.
And sometimes numbness.
Numbness on one side of the face can also occur, though it's a bit less common.
And then there's the crucial warning shot, the one that can happen before the catastrophe.
The leaking aneurysm. This produces what we call the sentinel headache. This isn't the full-blown rupture, it's a minor leak of blood that irritates the meninges, the layers around the brain.
And what does that feel like?
The patient will describe a sudden, incredibly severe headache. It might last for a few days and then just resolve. This is the body screaming a warning.
So any patient with a sudden, unusually severe headache, even if it gets better, needs an immediate workup.
Absolutely critical. The risk of a major rupture is significantly higher in the days and weeks after a sentinel leak.
And if that major rupture does occur, we get the symptom that everyone in the ER fears most.
The rupture.
Yeah.
And it is defined by the thunderclap headache.
Yeah.
The term is clinical shorthand for a reason.
Because it's instantaneous.
Literally. The headache reaches its maximum, crushing intensity in seconds. It's debilitating, and patients universally describe it as the worst headache of their entire life. That is the sign of a subarachnoid hemorrhage.
And this is such a devastating moment, we really can't gloss over the gravity of those statistics you mentioned earlier.
It's necessary context for the urgency. The immediate mortality is just staggering. Roughly 25% of people who suffer a ruptured aneurysm will die within the first 24 hours.
Before they even reach definitive care.
And of those who survive the initial event, a huge percentage will face severe long-term disability or death in the following weeks from complications like rebleeding or vasospasm. Time is truly brain tissue here.
So given that urgency, the diagnostic process has to be incredibly fast and accurate. What's the first step in the ER?
The first line of defense is a non-contrast CT scan of the head. It's fast, and it's highly sensitive for detecting blood in the subarachnoid space. That confirms the diagnosis of SAH.
And once you see the blood,
we often proceed immediately to a CT angiogram, or CTA. We inject contrast dye, and that gives us high-resolution 3D images of the blood vessels. It'll usually spot the aneurysm itself with 95 to 100% accuracy.
But a CT isn't foolproof, is it? Especially if the bleed is small or the patient comes in very early.
That's a classic neurology dilemma. If the symptoms are classic thunderclap, but the initial CT is clear, you absolutely cannot stop there.
So what's the next step?
You have to perform a lumbar puncture, a spinal tap. We draw some of the cerebrospinal fluid, the CSF, to look for evidence of blood.
You're looking for red blood cells.
Initially, yes. But even more definitively, after about 12 hours, we look for xanthochromia.
Which is the yellow pigment from broken down blood.
Exactly. Finding xanthochromia in the CSF is definitive proof that a subarachnoid hemorrhage has occurred, even if the CT missed that early, subtle bleed.
Okay, so moving beyond the acute emergency, when we're screening high-risk patients or doing follow-up, we use MR technology.
Right. MR angiography, or MRA, is a vital, non-invasive tool. It uses magnetic fields, so there's no radiation exposure like with a CT.
Which makes it ideal for screening family members or checking on a treated aneurysm over the long term.
For sure. Its one limitation is that its sensitivity is a bit lower than CTA for very small aneurysms, say less than 3 millimeters.
Now, I saw a mention of an experimental technique, high-resolution vessel wall imaging. What is that trying to show us that a normal MRA can't?
A standard MRA just shows us the blood flowing inside the vessel. HRVWI is trying to visualize the vessel wall itself.
And why is that important?
The theory is that unstable aneurysms, the ones about to rupture, will show signs of inflammation in the wall. That inflammation causes the wall to light up or enhance after you inject contrast.
So it could be a non-invasive way to identify which aneurysms are hot, so to speak, and need urgent treatment.
That's the hope, to separate the ones that need intervention from the ones that can be safely watched.
And finally, what's the anatomical gold standard? The definitive test for planning a repair.
That's still the cerebral angiogram, or digital subtraction angiography, the DSA. It's invasive. You have to thread a catheter from the groin all the way up to the brain.
But the detail is unparalleled.
Absolutely. It gives us the highest resolution, most dynamic picture of the vascular anatomy. It's the gold standard for defining the exact shape of the aneurysm neck, which is crucial for planning either a surgical or an endovascular repair.
Which brings us to the most difficult conversation of all, deciding whether to treat an unruptured aneurysm. The surgery has risks. How do you quantify the competing risks of rupture versus intervention?
We rely on some powerful predictive tools. The phases score is a widely used metric that gives us a standardized 5-year rupture probability.
And it's based on 6 key elements. Can you walk us through those?
Of course. First is P for population. We know that Japanese and Finnish populations have a higher baseline risk. H is for hypertension. A is for age. Older age slightly increases risk.
And S is for size.
S is for size, and size matters immensely. An aneurysm over 20 millimeters has a catastrophic risk. E is for earlier SAH from a different aneurysm. And finally, the second S is for site.
Meaning where in the brain it's located.
Right. Aneurysms in the posterior circulation or on the posterior communicating artery have a much higher rupture risk than those on the internal carotid artery.
So phases tells us the risk of the disease, but it doesn't factor in the risk of fixing it, which changes from person to person.
That's its critical limitation, and it's why the UIAT score was developed, the Unruptured Intracranial Aneurysm Treatment Score.
And that's designed for shared decision-making.
Exactly. It takes all the phases' risk factors, and then it integrates them with the estimated risks of the intervention.
So things like the patient's age and other health problems.
Yes. If the patient is very elderly, has heart disease, or if the aneurysm has a very complex shape, those factors add points against intervening.
So instead of just a rupture risk number, UIAT gives you a holistic risk-benefit ratio.
That's it. It lets you say to the patient, given your age and health, the chance of a severe complication from treatment is X%. The chance of a rupture without treatment is Y%. Which risk are you more comfortable with? It provides the framework for truly personalized neurosurgery.
Once that decision is made to treat, especially after a rupture, the goal is immediate. You have to exclude the aneurysm from the circulation. This brings us to the great neurosurgical debate: clipping versus coiling. Let's start with the classic approach.
The historical approach is surgical clipping. We're talking about a major open operation, a craniotomy, that's been around since 1937.
You temporarily remove a piece of the skull.
Right. The neurosurgeon then has to perform this incredibly delicate microdissection through the brain to get to the artery, identify the neck of the aneurysm, and then place a tiny titanium clip right across that neck.
The goal is mechanical and immediate.
Isolate the sac from blood flow, but preserve the main artery. It's a physical, permanent seal.
And its main advantage is durability. Why is it so robust long-term?
Because it physically reconstructs the defect. Long-term follow-up shows that clipping achieves a complete and lasting obliteration, meaning zero blood flow into the sac, in about 97.4% of cases. The clipped aneurysm effectively ceases to exist.
But the recovery is very demanding.
Very. Weeks in the hospital, long rehabilitation, especially if it was done after a subarachnoid hemorrhage.
Okay, now contrast that with the modern, less invasive approach that really changed the game in the 1990s. Endovascular coiling.
Coiling is done entirely from inside the blood vessel. We navigate a microcatheter, usually from the femoral artery in the leg, all the way up into the brain.
And once you're inside the aneurysm sac,
we start delivering these soft, flexible platinum coils. We just pack them in there until the sac is dense with them.
And that promotes clotting.
Right. The massive coils promotes thrombosis, a blood clot forms within the sac, and that's what seals it off from the inside.
The appeal is obvious, less invasive, quicker recovery. But the clinical trials, specifically the ISAT trial, highlighted a major durability problem. What did they find?
The ISAT trial was a landmark study. Initially, it showed coiling had better short-term outcomes at 1 year for ruptured aneurysms, but the long-term data was more complicated.
The vulnerability was recurrence.
Huge vulnerability. The follow-up showed a significant number, up to a third of patients needed retreatment within a year because the coils compacted. And critically, the rate of rebleeding in coiled aneurysms was 8 times higher than in clipped ones.
8 times? That's a catastrophic long-term trade-off. It suggests you're trading short-term safety for long-term risk.
Precisely. It created this dilemma. Clipping offers superior protection long-term, but coiling is safer up front.
So the question isn't which is better overall, but who benefits most from each approach. The Thai retrospective study gave us some clarity on that.
It did. The real-world data showed coiling significantly benefited 2 specific high-risk groups. First, patients who came in very poor neurological condition, what we call WFNS grade 4 or 5.
And for our listeners, what does a grade 4 or 5 patient look like?
A grade 4 patient is lethargic, maybe has some weakness on one side. A grade 5 patient is often in a coma or close to it, showing signs of severe brain injury.
And for those critically ill patients?
Them, coiling had a much higher rate of favorable outcome, almost 44% versus about 27% for clipping. The thinking is that avoiding a massive open surgery when the brain is already under so much stress is just safer.
That makes sense. And the second group was about surgical access.
Yes, the posterior circulation aneurysms. These are located deep in the back of the brain near the brainstem. They're incredibly difficult and risky to get to with open surgery.
And coiling was much better there.
Dramatically better. A 75% favorable outcome versus only 33% for clipping. This has really established endovascular techniques as the standard of care for those deep, complex aneurysms.
Now, as technology improves, simple coiling often isn't enough, especially for wide neck aneurysms where the coils could just fall out.
Right, for those we need scaffolding. A classic technique is balloon-assisted remodeling.
So you use a temporary balloon?
Exactly. We place a tiny uninflated balloon across the neck of the aneurysm, we inflate it, which creates a temporary wall, and we pack the coils in behind it. Then we deflate and remove the balloon.
And the big advantage there is avoiding blood thinners.
A huge advantage, especially after a rupture. It often avoids the need for long-term dual antiplatelet therapy.
But if the neck is extremely wide, a temporary balloon isn't enough. You need permanent scaffolding.
And that's where stent-assisted coiling comes in. We deploy a permanent mesh stent across the neck before we put the coils in. The stent acts as a stable barrier to hold the coils in place permanently.
But I have to ask about the risk of putting a stent in the brain, especially after a hemorrhage. Don't you need mandatory blood thinners?
You do, and that is the central clinical challenge. Anytime you place a stent, you risk a clot forming on it, which can cause an ischemic stroke. So stent-assisted coiling mandates dual antiplatelet therapy, usually aspirin and clopidogrel, for months.
Which increases the risk of bleeding complications.
It does. It's a crucial part of that UIETS risk-benefit calculation we talked about.
Let's talk about the ultimate evolution here, often for giant aneurysms. Flow diversion. How does that work? It's fundamentally different.
It's a total paradigm shift. We use these specialized low-porosity stents, like the pipeline device, but we're not trying to block the flow immediately or fill the sac.
You're just slowing the blood down.
Dramatically.
Yeah.
The mesh is so tight that it severely reduces the volume and velocity of blood getting into the aneurysm sac. You basically make the blood inside the aneurysm incredibly stagnant.
And the body's own healing process takes over.
Exactly. The stasis encourages new cells to grow across the neck of the aneurysm over 3 to 6 months, walling it off biologically. The sac slowly thromboses and shrinks. It's highly effective, but it requires diligent antiplatelet therapy for a long time.
And finally, there's a category that tries to bridge the gap: intrasaccular devices.
Right, things like the WBID device. They're designed to be placed entirely inside the aneurysm sac, especially for those wide neck bifurcation aneurysms.
So it disrupts the flow from the inside out?
Yes, it's a self-expanding mesh ball that immediately disrupts flow, promotes thrombosis, and because it has minimal contact with the parent artery, it often requires less intensive antiplatelet therapy.
All of this complexity requires incredible visualization. You mentioned the INSIGHT trial for neuro-optical coherence tomography, or nOCT. Why is a micron-level view so vital?
Well, our current imaging, the DSA, gives us a great outline, but it's just a shadow. When we deploy a stent or a flow diverter, its success depends entirely on it lying perfectly flat against the vessel wall. We call that apposition.
And if it's not perfectly flush?
You can get gaps, turbulence, clot formation. It can fail. nOCT uses light, not X-rays, to image the inside of the vessel wall and the device itself in micron-level resolution.
So you can see in real time if the stent is deployed perfectly.
Exactly. You can confirm perfect wall apposition immediately. And in the future, we might use it in follow-up to actually see the new tissue growing across the aneurysm neck. It moves the standard of care from just mechanical exclusion to confirming biological healing.
We've spent a lot of time on the crisis and the repair. Now we have to turn to what happens after the hospital. For survivors of a subarachnoid hemorrhage, recovery it's a marathon.
This section is maybe the most critical for understanding the human cost. And first, we have to emphasize that surviving it all is a monumental achievement.
Given the mortality rate.
Absolutely. But the recovery takes months, often years. And because survivors are frequently younger than other stroke patients, these long-term challenges hit their careers, their family lives, everything.
Let's start with the most insidious physical symptom: fatigue. This isn't just being tired.
Not at all. It's a profound, debilitating lack of physical and mental stamina that's completely out of proportion to any effort. It's neurological fatigue.
And it's incredibly common.
Up to 2/3 of survivors report significant fatigue 3 years or even longer after the event. It can make something as simple as grocery shopping feel like a monumental task.
And that fatigue is often compounded by sleep problems.
For sure. About 1/3 of people struggle with insomnia or fragmented sleep, which just perpetuates that fatigue cycle. It's very difficult to break.
Another constant physical issue is chronic pain, especially headaches that linger long after the thunderclap.
Yes, headaches are a long-term fixture for many. 2/3 of people report regular headaches more than 2 years later. They aren't the acute emergency level pain, but they just grind down your quality of life.
And what about sensory loss? This was particularly striking to me.
It's a common and really surprising consequence. 1/4 to 1/3 of patients experience a worsened or even a complete loss of their sense of smell and of taste.
And does that come back?
Crucially, it usually does not improve over time. And beyond just losing the pleasure of food, it can lead to decreased appetite and weight loss, which further impacts their overall recovery.
Now let's move into the cognitive sphere. The subtle but profound changes. The most universal finding seems to be slowed processing speed.
That is correct. Almost every survivor will tell you their brain is just running in a lower gear. Information is processed more slowly.
And that has immediate practical consequences.
Of course, for things like returning to driving or working in a fast-paced environment. Instructions that used to be absorbed instantly now require conscious effort and time to parse.
And the struggles with executive function are often described as the most debilitating barrier to returning to normal life.
Executive function is the brain's manager. It handles planning, sequencing, problem-solving, filtering distractions. And about 3/4 of survivors struggle with this.
So multitasking becomes nearly impossible.
Exactly. They struggle with starting tasks, switching between them, and they get cognitively overloaded in busy environments. So coping strategies become all about external management, meticulous calendars, breaking projects into tiny tasks, avoiding noisy, crowded places.
And memory issues are another major component.
Memory problems are extremely common, affecting more than half of survivors for over a year. It's often difficulty forming new memories. And it's completely normal, by the way, for survivors to have zero memory of the rupture itself or their acute hospital stay. It's kind of protective amnesia.
Beyond the neurological deficits, there's the immense emotional and social toll of surviving a near-death experience.
The emotional toll is huge. Initially, many experience what we call emotional dysregulation. Outbursts of anger, frustration, sudden tearfulness that they just can't control. That usually gets better.
But the lasting mental health impacts are severe.
The stats are striking. Half of patients experience significant depression and anxiety a year out. And the event itself is so traumatic that a third of survivors may develop post-traumatic stress disorder or PTSD.
And all of these changes can lead to feelings of isolation.
Of course. The physical and cognitive shifts lead to a loss of self-confidence, difficulty in social roles, and yes, profound isolation. This is why integrated long-term psychological support therapy, medication support groups is absolutely essential.
So let's close this section with a realistic timeline for getting back to life. Returning to work, for instance.
It's slow, but it is achievable. The data shows that roughly 2/3 of people do return to work, but that milestone is often reached somewhere between 2 and 4 years after the aneurysm.
And it's often not the same job.
Very often not. About a third of those who go back have to accept a modified role, a different job, fewer responsibilities, reduced hours, to accommodate the persistent deficits, especially that profound fatigue and slowed processing. The goal is a return to productivity, but that productivity often looks very different.
We've journeyed from the micro-level failure of a vessel wall all the way to the long-term adaptation of the survivor. What stands out is just the immense complexity of this condition.
It's a true medical and personal challenge. We've seen that dual nature, the silent formation driven by both lifestyle and genetics, and the catastrophic emergency it can become.
And the science of identifying who's at risk before that happens with things like the Ruptured DNA project, that feels like the most exciting frontier.
It is. And we understand the treatment trade-offs better now. Long-term data from trials like ISAT confirm that clipping is more durable. But the advances in endovascular tech mean that care has to be individualized.
Coiling has carved out its own vital place.
Absolutely. Its ability to benefit patients in poor condition or with those deep posterior circulation aneurysms is undeniable.
And I think the key takeaway from the recovery section is that the battle does not end in the operating room. The survivor faces years of these profound but often invisible challenges.
Crippling fatigue, cognitive deficits, severe emotional burdens. Long-term care must be about supporting their adaptation to this new normal.
And here's where it gets really interesting as we look forward. The future isn't just about a better clip or a better coil. It's about achieving unprecedented precision.
That's it. The development of micron-level visualization, like the nOCT system, is all about ensuring the durability of our endovascular repairs by confirming perfect deployment and watching that biological healing.
This push for precision and eventually for genetic prevention shifts the entire paradigm from being reactive to being proactive. Which brings us to our final provocative thought for you, the listener.
If a project like ROR DNA succeeds and genetic screening becomes commonplace, what happens when we identify millions of people who have a small, unruptured aneurysm that poses a low but non-zero risk, a population that otherwise would never have known?
What are the ethical and economic implications? How do we responsibly manage the immense emotional burden and anxiety we would be placing on those people?
The knowledge of carrying a potential time bomb, even with a low annual risk, fundamentally challenges the balance between providing life-saving information and causing unnecessary psychological harm and financial strain through mass surveillance.
The core of proactive healthcare is about to face its most profound dilemma.
A powerful thought to consider. Thank you for diving deep with us into the world of brain aneurysms. If you are on this journey, please look to resources like the Brain Aneurysm Foundation for support.
Until next time.